The phalanxes contain digital phalanxes. The bones on the top of the finger are digital phalanxes. The bones on the middle of the finger are viral phalanxes. The bones on the top of the finger are proximal phalanxes. The bones on the middle of the finger are metacarpal phalanxes. The bones on the middle of the finger are ridge joints. The ridge joints are called carpal bones. There are 8 carpal bones. The first is trapezoid, trapezium, capitate, hemate, escapoid, lunette, equilateral and pechabon. The second is radius and ulna. The radius, ulna, carpal bone and metacarpal joints are the ridge joints. These are the bones. There are also several bones on the hands. The bones are ligament, tendon, muscle, artery, vein. Here we see the names of muscles and tendons. The blue ones are tendons. The red ones are arteries. The blue ones are nerves. The pink ones are the thumb muscles. The palmar muscles are here. The blue part is the carpal ligament. The red part is the little finger muscles. The red part is the nerve. MRI advised doctors to treat the tumor in the hand for a long time. Then the ligament or tendon is infected. The tumor is in the muscles. Sometimes the tumor is in the bones. The MRI advised doctors to treat the tumor in the hand for a long time. The ridge joints are infected. Here we see that there are 2 surfaces of the hand. The palmar surface and the dorsum surface. The palmar surface is the dorsum surface. The dorsum surface is the upper part of the palm. The upper part of the palm is the palmar surface. The lower part is the dorsal surface. The upper part is the distal surface. The lower part is the proximal surface. These are the reasons why we know these things. Because we use these terms when we position the hand. Now we have the indication of MRI. Because MRI is being done. Marrow abnormalities, synovial base disorder, infectious of bone, joint or subtistic, neoplasm of bone, joint or subtistic. Neoplasm means tumor. Avascular necrosis, nerve impingement, fracture in child, tendons, subtistic muscles, occult fracture, ganglion cyst, ligament tear. These are the common indications of our hand. Now let's see how to position the hand. First, we see the hand and the wrist coil. Here we can see the hand and the wrist coil. The patient's heart can be placed inside the coil. The patient's position is that the hand will be in front. The patient will be in front position. This position is the Superman position. So we will keep the hand in the PA position. Yes, we will keep the hand in the PA position. The dorsal surface of the hand will be above and the palmar surface will be below. The hand will be in the hand and wrist coil. Here the hand is written twice. Hand and wrist coil or the large flex coil and immobilized in the cushion. Here is the large flex coil. If the hand and wrist coil does not stay in the position, then we can use the flexible coil. This is what it says. Now we will give support with foam and cushion. And we will center the metacarpal phalangeal joint. The metacarpal phalangeal joint is here. This is the metacarpal phalangeal joint. We will keep this joint in the middle of the coil. Then we will give the upper part of the joint as a support. After that, we will center the joint on the joint with a mask and a stick. We will do head fast supine for fashion registration. It is okay. It is okay. It is okay. We will position the head fast supine. The head fast is okay. But why should we do supine? This is in the front position. We will do supine because we are not normal anatomists. The hand stays down. Normal human body anatomists keep their hands down. But when we give our hands up, it will not be a front. It will be supine. So, if we give head fast supine, we will get the best image. From now on, we have the hand protocol. First, the localizer comes. Then there are two axials. One is T2 HDR and T1 HDR. Then there are two coronal. One is T1 coronal and the other is T2 HDR coronal. And there is a sedate. T2 HDR sedate. And if we use the contours, then we will get all the T1 headsets. Axial coronal and sedate. So, these protocols are our routine protocols. We can test these protocols with the help of radiologistic. So, if we scan like this, we will get these three localizers. Now, you can see that the first localizer has such a good image. What happened? Then what we do is that we do not repeat the localizer again. And again we plan in the palm of our hand. After planning, we get such a good image. So, until we get a good image, we can keep the localizer. So that we can plan the protocols properly. It is advisable to obtain additional localizers until you have acquired accurate axial coronal and sedate localizer. So, until we get an accurate localizer, we can repeat the localizer. Localizer does not take much time. It takes 20 to 25 seconds. So, now we are in axial planning. Axial planning means that this is the axial axis. There is a box on the axis. And the palm is on the coronal and sedate. So, we will give the palm on the coronal. Perpendicular to the metacarpal and pharyngeal bones. So, the metacarpal and pharyngeal bones are perpendicular to the size. And we will give the sedate plan. The sedate plan is that the bones in the palm, the size is perpendicular to the bones. And the size is that from the top of the finger, from the tip, to the joint of the distal radius of the finger. So, we have to take the size of the axial image. So, how to do coronal planning? So, we have to give the plan to the coronal, to the axial and sedate. So, we will give the plan to the axial. The size is parallel to the metacarpal bones. And the size is that the bones are parallel to the bones. And the plan of the sedate is that the metacarpal and pharyngeal bones are parallel. And the size is that the dorsal and palmax aspect, the whole hand is covered by the dorsal and palmax aspect. How to do the sedate planning. The sedate planning is done on the coronal and axial. So, we plan on the axial that the plan is perpendicular to the metacarpal bones. And we plan on the coronal that the metacarpal and pharyngeal bones are parallel.